Hello again. I'm Fatemeh. I am not Razmia, but Razmia wasn't able to come, so as her supervisor, I'm presenting our research. This is, as the title says, Cardiovascular Risk Assessment among Saudi university employees and their families. So cardiovascular disease is really the leading disease in the world and one of the biggest public health issues worldwide. And it's affecting not only developed countries, but also countries of economic transition. In fact, in those countries, because of the double burden of infectious disease, the situation is even worse. Going back to a presentation first thing in the morning, a lot of these are really linked with anti-inflammatory issues. So infectious disease is clearly linked with. Saudi Arabia has high prevalence of many vascular disease risk factors, including tobacco use, physical inactivity, overweight, obesity, diabetes, and hypertension. The potential effect of immigration on health has received attention in recent years, and in Saudi Arabia, like many Gulf countries, more than 1/3 of the workforce are expatriate, but no study has yet investigated that law. So the aim of this study was to assess the prevalence of cardiovascular risk among Saudi Arabia university employees and their families. I need to mention that when we are saying the employees included diverse range of groups, of not only academic and admin staff, but really sort of cleaner, everybody else. So although it's not sort of, you may argue it's not generalizable, but it covers a range of people. Another aspect was also, as it is a golden opportunity to look at and see whether migration has an impact on health. So here it was a good opportunity of having 1/3 of workforce from outside university, from outside the Saudi Arabia. But those of you who are familiar with obesity, we know one of the most important tools being used in the last 20 years is BMI. But there are a lot of debate and criticism about the fact that body mass index actually doesn't differentiate between muscles and fat. So that is not really a good tool to use, but it still is used. And in the last 10 years, another tool called weight for height has been highly recommended. So we thought that's a good opportunity to actually concurrently validate and see whether the same result you can get from waist circumference, from body mass index and weight for height. And finally, it was very important when you are doing this type of screening, it is an important ethical issue. You cannot just screen and do nothing about it, because you can have actually people, healthy people, entering in this room and becoming unhealthy. So it is ethical to actually do something about it. So that's why it's very much a practice-based research. So, and the idea also was, as there is no proper intervention program in Saudi Arabia, so to use this as a learning lesson, how to plan intervention program and management issue. Okay. The methodology used for this was the WHO stepwise questionnaire, which I had the pleasure of being part of the team to develop this tool. So it was really brilliant to be able to supervise someone to implement this tool. But because we were actually looking at the impact of migration, we had to add some additional questions and validate that before using it. Based on the sample size calculation, we required 4,500 participants, and the criteria for inclusion was there would be above 18-year-old and non-pregnant women. The study had 2 phases. In phase 1, we used the screening tool, the questionnaire, so as well as really finding out about socioeconomic data, but also about the lifestyle behaviors. But also, there have been a screen for the hypertension, diabetes, and whether they have hyperlipidemia or not. So, as well as the questionnaire, so we asked them whether they knew about the history. If not, whether they knew or not, we still did by chemical test. So their lipid profile, fasting blood glucose and hemoglobin was also assessed. We also did anthropometric measurements, so height, weight, waist circumference, and ankle circumference, but it's very much linked with the high blood pressure. Then, based on the risk identified, they have been, the score has been calculated based on the Framingham scale, which is a well-known scale, and people have been identified to low risk, intermediate risk, and high risk. And here, those who were intermediate risk, they have been referred to the dietitian, so to actually check and give them advice. And those who were identified at high risk, they've been referred to the cardiologist. So that is the intervention program in the phase 2, so after the identifying the need. Okay, so the way we recruited the participants, of course, after following the research governance and getting the ethical approval and their consent being gained, then they have been actually recruited from the university website, but also through different clinics the university had. And flyers were put up, so participation was really voluntary. If people could not read English, the Arabic translation of the questionnaire was also available. So here's just some photographs to just show you what's happening. They were waiting in the waiting room, and then here the research team were there. So, and different journeys. So it is really height and weight measurement, body circumference, and taking the blood pressure. So far, the first 1,000 participants' data been collected, analyzed, and because of the issue of really ethical issue, so it has to be analyzed and managed at the same time. The data so far shows that our non-Saudi participants have significantly higher level of education, university degree and plus. I guess the condition there is, you can't go and work in another country without having a degree, whereas, a lot of people who are working in university in Saudi Arabia, they could be either illiterate or have primary education or first degree. They were older, and high proportion of them were married. Interestingly, although marriage is actually supposed to be protective of heart health, in our population that didn't seem to be the case. So our non-Saudi participants had a sort of much higher. No, abdominal obesity was much higher amongst non-Saudis, although it wasn't really significant. But in terms of the overweight and obesity and morbid, they were totally different picture. There were more non-Saudis overweight, whereas obese and morbid obesity was much higher amongst the non-participants. Sorry, this is, okay. So when we calculated the risk factors, non-Saudis had significantly higher cardiovascular risk factors than Saudi. The tool I was talking about, weight for height measurement, had much stronger correlation with all other risk factors than body mass index and waist circumference. Again, another indication of really is important when you are looking at population outside the sort of European zone. You really need to consider about appropriate tool. Although our non-Saudis had significantly higher proportion of cardiovascular risk factors, but one of the reasons could be because they were older, so age could be an important factor as well as being male. So in the next stage of analysis, we are going to include those, both factors are going to be adjusted for. as I said, intermediates have been referred to the dietitian. So after 3 months, they would be followed up, and again, another screening would be done to ensure whether actually that intervention was helpful or not. Same thing with the cardiologist. They are referred to, and so far, we had 51 diabetes participants who've never been diagnosed, 51 participants with hyperlipidemia who's never been diagnosed, and 21 hypertensive participants who've never been diagnosed. So meaning that really at the moment, within the first 1,000, 5% of the total cohort started a medication because they did not know they had some of these risk factors. I think that's fine. Thank you. Thank you. I just realized